The continuous contraction and relaxation of the heart is due to the electrical conduction system of the heart. The electrical conduction system of the heart is a highly specialized network of muscle cells. Its sole mission is to initiate and transmit electrical impulses, ensuring the perfectly coordinated contraction of the cardiac muscle. It all begins with the primary pacemaker, the sinoatrial node or SA node. The SA node is located in the upper wall of the right atrium. It automatically generates the initial electrical impulse, typically setting the rhythm between 60 to 100 beats per minute. On an electrocardiogram, this impulse generates the P wave, which represents atrial depolarization. From the SA node, the impulse immediately travels through the internodal pathways within the atrial walls, transmitting the signal across the entire atria. The impulse then arrives at the atrioventricular node, or AV node, located in the floor of the right atrium near the septum. This is a critical regulatory point. The AV node performs a vital function. It deliberately delays the impulse. This delay is seen on the ECG as the PR interval, the pause between the P wave and the next complex, and it allows the atria to fully contract and complete ventricular filling before the main pump is activated. Once cleared, the impulse is transmitted to the bundle of His, or AV bundle, located in the upper ventricular septum. It acts as the signal's main freeway. This signal then divides, running rapidly down the heart septum via the left and right bundle branches. The rapid conduction through these branches, combined with the final steps, primarily forms the large QRS complex on the ECG, representing ventricular depolarization. Finally, the impulse is distributed by the Purkinje fibers, a fine network spreading throughout the entire ventricular myocardium. This final rapid distribution triggers the massive, coordinated contraction of the ventricular muscle, powerfully pushing blood out of the heart. When the precise electrical system fails, a dangerous condition known as heart block, or AV block, can occur. This happens when the signal controlling the heartbeat is delayed or completely blocked from traveling from the atria to the ventricles. Based on the severity of the conduction delay, heart block is categorized into 3 degrees. The first degree AV block is the least severe. All impulses are successfully conducted, but they are significantly slowed down. On the ECG, this presents as a constant, prolonged PR interval. The pause is simply too long, though every P wave is followed by a QRS complex. Next is the second degree AV block, where some impulses fail to reach the ventricles, resulting in skipped beats and a dropped QRS complex. This has 2 critical types. First, Mobitz type 1, also called Wenckebach. Here, the PR interval progressively lengthens with each beat until a QRS complex is suddenly dropped. The cycle then repeats. Second, Mobitz type 2. In this more serious form, the PR interval remains constant, but some P waves are completely blocked and fail to produce a QRS complex, indicating a potential block lower down in the conduction system. The most life-threatening is the third degree AV block. This represents a complete failure of impulse conduction. The atria and ventricles beat independently, a dangerous state called AV dissociation. The ventricles must initiate their own slow, desperate escape rhythm to sustain life. This is a medical emergency requiring immediate attention. For symptomatic, high-degree blocks like Mobitz type 2 and third-degree AV block, the long-term solution is often the implantation of a permanent pacemaker to restore the electrical system. The most common procedure is the transvenous approach. Leads are inserted through a vein, typically near the collarbone, and guided under X-ray into the heart chambers. The leads are then secured to the heart's inner lining, the endocardium. The pacemaker generator itself is implanted in the subcutaneous tissue, usually placed neatly below the skin in the chest area. A less common method, typically used for infants and children, is the epicardial approach, where leads are surgically attached to the heart's outer layer, the epicardium. While sometimes necessary, this is a more invasive procedure. Don't forget to subscribe and comment if you learn from the video. Stay safe and connected.